2 questions before we close. Whoever has the microphones, and I see Dr. Harmon's hand up for one of them.
I'm Bob Harmon with Cerner Corporation, and we provide electronic health records to a number of jail and prison systems around the country, including Cook County, LA County, and California Department of Corrections. A question for Homer. Have you been using direct secure messaging, secure email to communicate with providers outside of the jail system? And second of all, have you been able to get interoperability among your different systems within your own organization, such as the offender management system and pharmacy?
So we do not use that type of emailing messaging. We do have reports that get pushed out from the health record. We actually have several interfaces that Rick and his team have built with BioReference, with actually a couple of lab companies, with the jail management system. We just bought we have a new pharmacy system and have integrated that. And so we have multiple interfaces that we built, and that's really, without them, you know, there are upsides to the EHR, but certainly those interfaces are what make it, you know, more efficient and better for patient care. And so we have, along the way, built several interfaces, yeah.
So for those who don't know what direct secure messaging is, and I'm not sure if it was on your glossary.
It is in the glossary.
It is what I was sort of talking about when I talked about creating a document and sending it, but it can be decomposed, if you will, as well, with the wrapper that comes around it that knows how to interpret it. But the most important thing about it is that the use case really is, I know where the patient's going. And so if I'm a primary care and I'm referring to a surgeon, you use direct secure messaging because I know who has to get the data and I send it to them. And then if they refer or they want to send me a note back, they can use that to come back. Part of the issue with the exchange in the country is you don't always know where the patient's going to go next. And so that's more the use case that you're talking about. You're putting data out there in an exchange, and this one you may or may not want to remember. This is called a query model instead of a direct model. But in a query model, you put the patient out there, and I know you probably know this, and you wait for people to inquire or query the database to pull the information back because you don't know who's going to need it. And it's just 2 different models that we have in the country right now. And most states actually have both stood up. Kind of depends which one's stronger and, you know, what the use cases really are.
And before we do that, Matt Kelly, are you here? Can I give you a big shout out, thank you, for all of your work on the glossary that you did with Ben so much to update it that everyone now has. And we have time for one more question. Well, great.
Can I say one thing then?
Yes, ma'am.
So a shout out to Cerner because they happen to be the one that I was talking about with the pilot at Inova related to data segmentation. And again, they've jumped ahead of the market on this one, and I think it's going to be important work for everybody to watch.
We actually made a follow-up appointment to meet with Bob to talk about that as well. Well, great. Thank you very much for the panel.
Thanks.
For those of you who don't know, Amtrak is not running north at the moment. All the Amtrak North trains are delayed. So if you had an Amtrak North train, you get to sit around for another 5 or 10 minutes to listen to our closing remarks. Michael?
Thank you, Judy. Thank you, Linda. Thanks, Homer.
Okay, so we're going to wrap it up here. I want to first thank all of you for participating in this very important and very productive, very challenging conversation. I think we've covered quite a bit of ground today, and I think we clearly see that our work is still cut out for us. We at COCHS have always perceived our work as addressing civil rights to a large extent, and we've approached the issues via health care, but we see them essentially as being about civil rights and social justice. So the issues that we've taken on together here in this very room since 2010, was it November 2010, are issues that most people don't really want to talk about. These are issues that kind of make people uncomfortable because at the core, they speak to the issue of mass incarceration of young guys of color, poor guys of color who suffer from mental illnesses and addiction. And so, even though we approach it from the health standpoint, we think that the Affordable Care Act creates a frame in which this highly disenfranchised population, for the first time, has an opportunity to take a seat at the lunch counter. But I am old enough to remember the sit-ins at Woolworth back in the 60s, in Greensboro, where it took 4 years after the sit-in before folks had the real entitlement to service. So when we translate that into health reform and the ACA, the real question is, now that it's here, how long will it take before it really catches on and we really see the movement? So there are a lot of things that we still don't know about the ACA and how it will play out with the justice system involvement, but there's a lot we do know. And so from here, I guess the big tee-up question would be, so who will serve them? This is one of the big questions. We're going to put that out on the table. Who will serve them? Will it be the community providers? Just who will it be? We're going to let Steve kind of take a stab at a couple of these.
Thanks, Mike. As I think Mike said, we perceive the going forward course here to be very technical and very implementation. And I'd like to talk about those within some very specific issues. So if you think about the lack of capacity, we all know that right now we don't have capacity in our communities to serve the mental health and substance abuse needs of this community. Where's that capacity going to come from? Is it going to come from the community-based nonprofit world? Is it going to come from public counties? My best example is Bain Capital just bought up the methadone maintenance clinics in 6 New England states, New Jersey and Pennsylvania. Is it going to come from private equity? Okay, Bain Capital, Mitch Romney's company, right? Romney Care. No, this is not Romney Care, folks. It's a business opportunity. Okay, a large private equity firm just bought 80% of the stock of the largest correctional healthcare provider in California. Okay, this is a process that is going on. CCS and GEO Group just combined. The GEO Group Mental Health Services just became part of CCS. Corizon just brought in a new CEO, Woody Myers, who was a public health director, right? That the environment is changing, and the environment is changing because this question of who will provide these services to which folks now have an entitlement is now on the table. And this is all, we are exactly 3 months and 3 days into healthcare reform, and this is already happening. So one of the crucial questions is that, who will serve them? The other question, I think, will be, what will be available? Paul Samuels mentioned that in New York State, there's a mandate that court-ordered services be provided under the insurance program. That's actually the opposite of what exists in most other states, where insurance companies have gone to benefit exclusions that said that they get to exclude court-ordered services from coverage. Well, that's crazy if that's part of what we're doing now. If a service is medically necessary, why does it matter whether it's court-ordered or not? Okay? But this whole question is now, again, a very specific implementation question. Okay? Who will define medical necessity? How will it be defined? Will it be defined by the plans? Will it be defined by states? How will this whole issue of what will be available be there? The IMD exception, which was articulately referred to by Elena, probably the biggest need for justice-involved individuals is going to involve residential recovery at some point. What is the IMD exclusion going to mean? How is that going to handle? That parity is the rule, but the question is going to be operational. I think the other thing we don't know is what this will cost. Paul mentioned the work that's been going on in New York State there was some analysis done. This is not justice involved. These are just folks with mental health and substance abuse needs where they've gone back and they've looked at claims data on what those individuals are spending in claims, and we're talking about $1,800 per member per month is what some of those severe folks are costing in claims. So are we willing as a society to make such a large investment in stabilizing the health, safety, and social systems that we rely on? I would take it even further and see we don't even know if we are prepared to understand the price we are going to pay for decades of neglecting this population, that in keeping this population hidden, we are going to pay a price into the future that we do not know what that is. So as we can see, these are not small, or insignificant issues that remain before us as we figure out how to go beyond the 3 months and 3 days into an implementation of a vision we articulated in this very room over 3.5 years ago. For us at COCHS, our goal has been to articulate a new policy frame by addressing the needs of jail-involved individuals within the mainstream health system. Can I say those words again? Within the mainstream health system, so that correctional medicine, correctional health as we've known it, becomes part and parcel of the mainstream health system. In doing that, the disenfranchised, at least in some fashion, become enfranchised. This goes back to the question that I answered to Matt earlier this morning when he said, well, what does it mean, this issue of Medicaid paying for hospitalization? And what I said is it means I bring quality assurance, utilization review, and prior approval. Those are tools of enfranchisement. Those are tools that we use within our healthcare system to make sure that everyone is treated equally and that human rights and equal rights are values that we all share. Making all of this happen will require commitment and hard work, not only by all of you in this room, but by many others who are not in this room. In the 3.5 years, we have made tremendous progress. And we at COCHS are incredibly proud, and I want to shout out again to Nan, to my staff in the back, Ben Butler, Mike, Dr. Keith Barton, David Horowitz, Matt Bekele, Julia Kaiser, Dan Mistak, for all of us for making this possible. The silos that had kept us apart and we have in some micro fashion in this room and bringing you all together, we have crossed those silos and brought them together. And we've done a tremendous job of recognizing the opportunity the Affordable Care Act has given us. Health reform is upon us. $7.1 million people enrolled in coverage through the exchanges, approximately another 1 million folks enrolled in the same risk pools through the individual market. As Marsha Regenstein told us, a significant number of those are going to have involvement with the justice system. A new phase of this work is upon us to ensure that healthcare policy and planning, that efforts in state and local jurisdictions, that public safety and correction systems naturally consider each other as their partners, and that we follow through on this vision we have created. And thanks to the good work of the panelists on the stage, the authors, and you and the audience today, this work can still evolve. Philanthropy seeded this market. You've all heard us thank philanthropy several times. We are here today because philanthropy seeded this market to ensure that the criminal justice population was included in healthcare policy considerations. This did not happen out of thin air. To make this vulnerable, high-risk, high-cost segment of our society visible. Those of us in this room need to continue to ensure that this population retains that right and that access of their newly found entitlement. COCHS has been very gratified to work with you for the past few years. And in particular, we want to extend our gratitude to the Robert Wood Johnson Foundation for its core support that began 9 years ago when Nancy and I first made our trip to Hampton County, Massachusetts. We wouldn't be here, and I don't think this issue would have progressed without the support of the foundation, and especially Nancy's support, COCHS' board support, COCHS' advisory committee support, our staff support, and most of all from you. But like all good things must come to an end, the Foundation's core support of coaches, which has carried us forward for these 9 years, is likely to end within a short time. So the questions I ask you are, how do we carry this forward? How do we continue to operate across all of our silos to ensure that the opportunities created by healthcare reform are leveraged to their maximum extent? And how do we ensure that the policy changes, many of which you just heard me recite, how do we assure that everyone gets a seat at Mike's lunch counter and that we don't have to wait the 4 years before we take that vision and turn it into reality? That's a lot to think about. That's a lot to ask you about. On that note, I want to thank you all again for being here. I want to remind you to fill out your evaluations, as Nan encourages me to do. I want to tell you that within the next week, this conference, which was webcast live today, to over 100 attendees. Okay, remember, folks, we had 225 seats. We had 281 of you registered for this meeting, and we had another 100 folks watching on the webcast because this is such a topic. This will be available in the webcast for those of you to share with your colleagues sometime next week. Thank you, Paul Seltzer and Spark Digital, for making that happen. And thank you once again, all of you, and safe travels. Thank you very much.